Welcome to the DaVinci Hour, a podcast series that interviews individuals across the field of medicine to help provide an inside look into their experiences and provide insight on how to navigate the journey of becoming a physician. My name is Dr. Maxwell Cooper, and I will be your host. This podcast is brought to you by DaVinci Academy, a medical education company that provides online video courses, outline format books, and clinical case videos for students studying the medical basic sciences. You can check out all that DaVinci Academy has to offer at www.dviacademy.com.
All right, everybody, welcome back to the DaVinci Hour podcast. Happy to welcome my guest, Dr. Juma, to the podcast. Dr. Juma is actually an attending neurologist at ProMedica Health System and University of Toledo Medical Center in Toledo, Ohio. And he specializes in cerebral vascular medicine, stroke, and interventional neurology, which is really cool. He started his career with his residency at the University of Pittsburgh Medical Center, where he did neurology residency and then fellowships in vascular neurology and interventional neurology. And so we're happy to have you. Welcome to the program, Dr. Juma.
Thank you, Max. And I'm very happy to be with you today and excited to answer all of the questions and talk to the medical students about interventional neurology.
Excellent. So I gave a little bit of background, but maybe you tell us about your current position. Like, what types of patients do you see? What type of pathology do you see? Like, how do your days kind of break down, and what kind of practice setting you're in?
Yeah, so I'm an associate professor in the Department of Neurology at the University of Toledo. I also lead the stroke program at University of Toledo and ProMedica. This is a large stroke program that we started, me and my partner, Dr. Zeddy, in 2012. We started with 2 physicians, and now we have 6 doctors, and we have 8 advanced practice providers, and a lot of residents and fellows rotating with us on service. So as you mentioned, after I finished medical schools overseas in Damascus, I went to University of Pittsburgh and I did neurology residency, and then I specialized in vascular neurology and then interventional neurology. So that took me 8 years, and I'm sure we're going to talk about this when I answer your other questions. But what I do now is actually a mix of, a few things. So I'm a stroke physician by training. So I spend about 14 weeks per year rounding on the inpatient stroke service, sometimes 12 weeks, sometimes 14 weeks per year. And then I'm an interventional neurologist. So I do 18 weeks of interventional neurology per year. I have 2 other partners, so we split the year 3 ways. I do this when I'm not rounding on the stroke service. And then I also do a half day of clinic for interventional patients per week. I also do, a lot of education and research, and, so the rest of my time is mostly dedicated for doing for catching up on, clinical activity and for doing some of the research and education.
Awesome. That's cool. So it sounds like you're definitely an academic physician, but from what I understand, it sounds like you cover 2 types of hospitals. From what I remember, the ProMedica system, maybe a little bit more of a community type hospital, or maybe even a lot of private practice physicians, but then you also are involved, with, like you said, with residents and research. Is it kind of like a hybrid model, would you say?
So a lot of that has changed since you left. A lot of the practice now is, we have a comprehensive stroke center, and this is a joint commission designation where we have the majority of our patients at Toledo Hospital, and that's where all the residents and the fellows rotate. Okay. But, stroke care has expanded so much in the last 10 years or 15 years. So a lot of practices have a mix of, a main hub, which is typically a comprehensive stroke center where they spend the majority of their time. And then they have some community outreach. Okay, so, I can tell you a little bit about how we do things, but the idea is that we actually have a comprehensive stroke center where 18 hospitals feed us the high acuity cases. Okay, now the lower acuity cases, there's no reason for them, especially in the, this day and age of COVID, there's no reason for them to come to a higher level of care. So we do our best to keep them safely in their own communities. And we do this by utilizing telestroke. Okay. I forgot to mention this to you, that I actually do a lot of telestroke coverage as well. So we have a telestroke service that's very well staffed with advanced practice providers and physicians. And we e-round every day on patients in their own community hospitals. So we see an equal number to the patients that we see at the Comprehensive Stroke Center outside in the community using the telestroke equipment. So we have a camera or two cameras, they're actually more of a computer on wheels, and it has a camera that allows us to pan and tilt and zoom, and we can log in and the patient can see the physician, and we can also see the patient and the family, and zoom in, zoom out, do the neurological examination, talk to the family, discuss treatment options, discuss what needs to be done after, and then provide the same level of care that we provide at the Comprehensive Stroke Center in the community. At the same level of care, you're doing the same thing, you're reviewing the same studies, and obviously getting the patients to the right place for rehabilitation or skilled nursing facilities. So that's really our community outreach. We do, we go to a couple of community hospitals to do some procedures, but the majority of our work now is at the Comprehensive Stroke Center. This is a very hot topic in stroke now, because there's so many stroke patients out there. The question is, should we remain centralized or should we decentralize some of the care and get the physicians out to the community and have them go out and do some of the procedures in outlying hospitals? So this is a very interesting topic in our field now.
Yeah, that is interesting. Would you say it's similar to how interventional cardiology kind of triages, STEMIs and the other interventional cases they do?
Yeah. So, you have some mixed data, right? So you have data showing that high volume places perform much better than low volume places. But you also have data showing that, long distance from your zip code or your residence to a place that can perform, for example, in PCI, in the case of cardiology or stroke interventions, would actually determine your outcome. So, if you live in a rural area, your access to stroke care is much less, your access to acute coronary care is much less. And then also your outcome will be defined by weather that day, whether there's any, snowstorm where they can't fly, transportation, are you going by ground, is the hospital connected well to another tertiary care center or high level of care where they can actually seamlessly transfer patients. So a lot of those things play into how we do things. But so far, the majority of stroke care in the country has remained centralized. I think probably shifted a little bit in the last 5 years, where we're reaching out to medium-sized community hospitals and trying to deliver some of the acute interventions. But I think the majority of stroke care has remained centralized, where you actually have a hub or a comprehensive stroke center, and then several hospitals feeding that comprehensive stroke center, taking into account that you have to keep your transportation protocols very efficient.
Gotcha. Okay. When you're on the inpatient interventional service, I guess maybe walk us through what your typical, I realize maybe you don't have a typical day because things change so much and you're dealing with different types of patients, but maybe like kind of maybe in your mind, your typical day on that service.
So, in my personal opinion, this is really the most exciting thing about being an interventional and vascular neurologist. Your job is a mix of different things. So you don't do the same thing, every single day. You're not repeating the same sequence. Routine. Your routine is, there is a certain routine that you have to live with. And I think routine sometimes is good for physicians because you become more efficient and your quality of care goes up. But at the same time, your routine is not too boring. Okay. So, 15, 20 years out of your practice, out of your training, you're going to continue to enjoy what you do. So my work, when I'm on the stroke service, I round with residents, just like any other medical service. I round with residents and fellows and advanced practice providers. We have vascular neurology fellowship here, so we always have fellows on the stroke service. So, I go around on typically about 30 patients. That takes about half day. And then the rest of the time, you're trying to, do your notes, talk to families, get things done, and catching up on some of the studies that you did not review during rounds. So that's how we spend our day when we're doing rounds, okay? When we're on the interventional service, typically you're booked with procedures. So from 8 to 5, you have, either your elective cases that you're bringing from clinic or patients who are referred from the stroke service for diagnostic angiograms or carotid stenting or stenting of vertebral artery. We also take care of the majority of the hemorrhagic disease here together with the neurosurgeons. So we admit most hemorrhagic stroke cases to the stroke service. So, we treat brain aneurysms, arteriovenous malformations. So usually our day when we're doing interventions is booked with procedures. And you don't do any other clinical activities at that time. We do some telestroke because you can actually do it from any location. So we have a setup in the angio suite where we can log in and examine patients in outside facilities. You can also do it from your phone. So tele is easily accessible. You can you can log in for tele from your own phone. When we're in clinic, we do half day of clinic when you're, obviously just like any other routine clinic, but usually most patients have been screened by a primary care physician, by a specialist, typically a neurologist, sometimes even by a vascular neurologist who is referring the case to you. So our clinics are very problem focused. A lot of stroke issues or a lot of aneurysm issues or AVMs have other components to them. They have other medical comorbidities that you have to address and manage. So we do that management. So we give some advice as primary care level of advice, but we typically like to run everything through the primary care physicians. So, majority of our stroke patients have hypertension, right? So, we try to address the hypertension issue, help the patient pick the right medications, talk to them about, keeping a blood pressure diary, a lot of the, secondary prevention tasks of taking care of stroke patients to make sure that they don't have any subsequent strokes. A lot of our clinic patients are coming for an opinion regarding endovascular treatment or surgical treatment, so we do that too in clinic. And then, like I told you, we have the telestroke component. So many times when we're covering telestroke, you're just logged in, just like now, on a Zoom-like call where you actually have a HIPAA-compliant software where you're doing audio and video conference with the patient. We also do some tele-clinics now because of COVID. And then we spend the rest of the time doing community education. I work very closely with EMS, so I've been doing work with the emergency medical services since July of 2015. We have very advanced protocols in the city of Toledo that we actually put together immediately after the stroke thrombectomy became standard of care. So we have, we spend a lot of time educating community, educating EMS, educating our colleagues. And then we obviously work with medical students and residents and fellows.
Gotcha. Okay. So I guess kind of going off the procedure side of things, what are like the typical elective procedures you talk about where you'll schedule people either from, they're on the stroke service on the inpatient side or people you've brought in from clinic versus like your more high acuity, like when you're on call?
Yeah. So we do, we do close to maybe 900 procedures per year as a practice, and about 40 to 50% of those procedures are interventions. The rest are diagnostic studies. Okay, so the interventions can be either acute, like the case of an acute ischemic stroke, or a case of subarachnoid hemorrhage, or they can be subacute, like a case of carotid stenting for stroke prevention, or some sort of treatment for an arteriovenous malformation 2 weeks after rupture, or they can be elective for cases that would come to your clinic with a brain aneurysm or newly diagnosed arteriovenous malformation, and they come to your procedure suite or your angio suite for elective treatment. Okay, so those are the types of procedures that we do. The acute procedures have really, I'm sure you're aware, but since stroke thrombectomy indications have been established and then expanded over the years, we can treat now up to 24 hours from the last seen normal. So the stroke volumes have gone up pretty significantly. We do about 200 stroke thrombectomies in our practice, which is considered a medium to high number. And those can come at any time. They come in at 9 a.m., they can come in at 2 p.m., they can come in during your time with your family, with your kids, during your lectures, when you're trying to, give a lecture to medical students. They can come in, in the middle of the night at 2 a.m., at 4 a.m. So those are very unpredictable. We just have to do them when they show up. And we have a very limited time to, to wrap up whatever you're doing so that you can keep going with that. We have target goals of, door to TPA and door to groin puncture time. And I'm sure many of the medical students have seen those times when they rotate with their stroke team or their neurology department. But, we we monitor our data very closely, and there's always a process improvement going on in the background. So we try to monitor those times very closely, and then be able to do those acute treatments very rapidly. So those, whenever they show up, you just have to find a way to fit them in. We have 2 biplane suites, so we many times you're doing an elective case and your colleague would come in, called in for backup or emergency to be able to do the other stroke in the other biplane suite.
Gotcha.
We're going to take a quick break to let you know the DaVinci Hour podcast is brought to you by DaVinci Academy, which provides online video courses for the medical basic sciences. These courses are taught using a variety of teaching methods, including bullet point outlines, diagrams, radiology images, and chalk talks to explain the fundamental concepts. We then teach the application of those concepts to numerous clinical pearls that are frequently tested on medical school exams and the USMLE. Our video courses are available on our website, dviacademy.com, as monthly subscriptions starting at $9.99 per month. Each video course has a corresponding outline format textbook as well. You can find the link to our website in the description below. Also, be sure to use the discount code TDH20 to receive 20% off any of our video courses. All right, now back to the podcast.
Now, when you do those, when you have those dedicated weeks that you're on neurointerventional, are you on call as well, or are you only doing elective procedures during some of those weeks?
Yeah, so the call is more of a rotation call between us. We tried the call, we tried to go on for a week where you do interventions and then you're on call every night, and it's not very it's not very humane, I have to say. So sometimes you end up getting slammed with a bunch of calls at night, and you have to show up, and you have really tough cases the next morning. So we try to protect each other. It's key to have a supportive team where you can actually make sure that the team is splitting the work equally, so that you can have longevity and also job satisfaction. Job satisfaction issues mostly come from the team that you're working with, right? So if you're enjoying working with a certain team, we have a fantastic team here that I think it's gone above and beyond in the last few years. We started off, like I told you, with 2 people, and now we have a team of about 20 people on the stroke service and cerebrovascular services. And the team really makes it or breaks it for you as a physician, especially for junior physicians. So you really have to make sure that you have supportive partners that you can work with, and be able to split the call. The way we do it is that, for example, I take every Tuesday night, my partner takes Monday night, the other partner takes Wednesday, and then we rotate the Thursday nights. The weekend is covered typically by one physician from Friday 5 p.m. all the way until Monday 8 a.m. But the weeknights, we usually try to rotate them.
I see. Okay. When you are on call, how does that typically go? Are you kind of doing business as usual, and then do you get, like you said, get calls and kind of fit things in, or is that typically how your call shifts will run?
When you're on call, you're at home, so we don't stay in house overnight. Okay. And then we take the calls from home. We triage a lot of our patients. We have, lots of bells and whistles now in stroke care. So, obviously, when you can imagine when you have 18 hospitals sending you patients, you have to be readily available for them. So we have a central line for acute stroke care. And then we also have a software, not to advertise for Rapid, but Rapid was one of the first softwares that became available for stroke physicians. And, this is the software that we use. So on your phone, you can access all the hospitals that we work with. And most stroke networks have this type of, AI software. The software allows you to communicate with outside hospitals. It allows you to read images right away as soon as they happen. So as the patient is in the CT scanner, the CTs are uploaded to your phone practically. So it's uploaded to a server or to a cloud-based storage, and then gets pushed back to your phone. So you can actually see the pictures probably about 5 minutes after they're done in the CT scanner, and you can make immediate decisions. So a lot of the phone calls that we do at night have to do with, decision-making, admit the patient, do aspirin versus, start heparin drip versus lower the blood pressure, raise the blood pressure versus, give TPA, don't give TPA. or go to mechanical thrombectomy. So when you decide to go to mechanical thrombectomy, you just have to come in and treat the patient. Or if there's any other need for an acute intervention, sometimes we get acute hemorrhages or we get acute ENT hemorrhages that we intervene on, and those usually require immediate treatments. So you have to be easily accessible. The one thing about this specialty is that you have to keep your phone on all the time. So, your partner may be scrubbed in a procedure and they cannot reach your partner. So you always have to be accessible for physicians who are used to calling you because they want immediate answers. The disease is very time sensitive, so you can't just, wait for half an hour to answer your call.
I see. And just to clarify, when you are doing your inpatient months, like your stroke, when you're covering the stroke service, the inpatient service, do you typically will do call as well on those, or is it only during those kind of dedicated interventional months that you said?
No, we do. I take typically one night per week.
Okay.
And 1 weekend every 3.
I see. Okay.
Yeah.
Gotcha. Okay. And then I guess kind of winding things back a little bit, and I feel like you touched a little bit of this when you were more earlier in your career, when you were a medical student or an intern, what kind of made you gravitate towards this type of work?
I have to say I was very intrigued by neuroanatomy early on when I started my pre-med years, and I always enjoyed understanding the central nervous system. And then we had a very strong family history of Parkinson's disease. So my dad was getting treated for Parkinson's disease, and I used to go with him to a neurologist's office. And this neurologist was super talented. This is overseas in Damascus. Fantastic neurologist who was like probably the top neurologist in the country. And every day he would have about 80 patients coming to see him. So in my last couple of years in medical school, especially as a senior medical student, I actually spent a lot of time with him. So I would go to his clinic and help him out and learn about neurology. So initially I was more interested in the outpatient neurology care. Okay. And then, decided that neurology is the right thing for me to do. Obviously more intrigued by movement disorders and neurodegenerative diseases, based on the things that I've seen. I really liked epilepsy as well. He used to take care of a very large population of epilepsy patients. And a lot of those patients are very young, and you can actually make a huge difference in their care day to day. And then I matched at the University of Pittsburgh. I interviewed in 12 places, and I matched at the University of Pittsburgh. And this was, I went to Pittsburgh in 2004. And that was the time when the first generation of neurologists were finishing up their interventional training. Okay. I think neurologists started going into the field in 2000 or 2001. So, I was really impressed by the work that was done by my mentor at the University of Pittsburgh, Dr. Tudor Jovan, who has just graduated at that time. And, he started working as an attending. He was, this is 2004, so 11 years before mechanical thrombectomy, before it became standard of care. Okay. So he was doing some selective cases that are very carefully looked at and selected, and neurologists would agree with the ER physician who would run it by the neurosurgeon or radiology. A lot of discussions about mechanical thrombectomy, they take about 2 hours, very different from today. Today we just go full speed and we try to open up the blood vessel in a short period of time. But the discussions were very intriguing. They were doing amazing things, collaborative work with neurosurgery and neuroradiology. And I spent a lot of time with them when I was a resident, and, decided to completely go in a different direction, right? So I became less interested in outpatient neurology care, and I became a lot more interested in acute care, and especially stroke care. So I decided to go for a stroke fellowship. I was debating stroke versus neurocritical care at that time, but obviously stroke was a clearer pathway to interventional neurology. And I was fortunate to be able to stay on board and train in interventional neurology at the University of Pittsburgh. We had a very robust team of neurologists and neurosurgeons doing really nice work, very high volume of cases, really nice mix of pathology that we were seeing, ischemic and hemorrhagic diseases. And that's really what really made me go toward interventional neurology. It's really that you can never underestimate the impact of mentorship, right? So, in my medical school, was influenced by a fantastic mentor who kind of got me into neurology. Same thing during residency. I had a fantastic mentor who got me into vascular and interventional neurology. So, mentorship is very essential. I'm sure, a lot of the medical students had similar experiences. And now as an associate professor, I try to pay attention to this because I know, what we do, what we say, the, type of care that we provide to our patients and the way we deliver information or science to medical students can actually really affect their decisions. I think probably more than 80% of medical students decide to go to a certain field because they were impressed by the people they worked with, more than just liking the field itself.
Gotcha. And I guess you said your interest in neurology initially lied in kind of the more outpatient setting, and then you shifted, obviously, because of these mentors, towards the more of the vascular, which is more of an inpatient side, and then the interventions. Yeah. I guess, was there like a moment or a particular rotation that made you switch that, or you found that you liked more high acuity type situations, or I guess were there any type of like the nature of that or the experiences that kind of shifted you towards going that direction?
Well, I mean, I think the most powerful thing was just seeing someone who's coming in with an acute stroke syndrome, mm-hmm. right, paralyzed on one side of their body, and coming back on service the next day and seeing how much they improved after they had mechanical thrombectomy. And again, there were very limited indications at that time. So, the busiest place in the country was doing about 25 or 30 cases per year. Now the average place in the country is doing about 100 plus cases per year, right? So very limited indications, but to see a young person improving so rapidly, we were fortunate enough to train in an era where the field was expanding very quickly, and there were devices that are getting approved by the FDA. A lot of talented people finishing their training and kind of advancing the science and advancing the field. So, I think watching that patient improve was really the moment when I was like, yeah, this is exactly what I want to do. Obviously, as you know, neurological diseases are tough, and a lot of people are not attracted to neurology, mainly because neurological diseases are very tough to treat, right? So you hear this all the time. The classic teaching in neurology used to be more diagnostic and prognostic. So you would go into the room, tell the patient what they have, and tell them what their prognosis is, but you don't necessarily give them a treatment. Okay. Well, that has actually changed very dramatically in the last 15 to 20 years. So we have many medications that have been approved for multiple sclerosis. There are tons of antiepileptics that have been approved. Mechanical thrombectomy obviously is a very powerful treatment for acute ischemic stroke. You have better treatment for hemorrhagic disease, and I think neuromuscular diseases, enzyme therapy, so I mean, every subspecialty in neurology has actually been has advanced very, very dramatically in the last 15 years, and the field has actually shifted. Today, to be completely honest with you, I mean, there's many multiple sclerosis medications that I'm not even familiar with because the field has advanced so quickly in the last 10 years. So from the time I finished my neurology training, and I don't take care of MS patients, most of my work is actually in cerebrovascular diseases. But the amount of new information, new science, and new medications is actually a little bit overwhelming. So neurology is becoming very subspecialized for this reason. So, the MS patient doesn't take care of Parkinson's patients. The MS physician doesn't take care of, Parkinson's patients. The Parkinson's doctor doesn't take care of other subspecialties. Most neurologists, except for the stroke physicians, do not take care of stroke patients because, the field has changed so dramatically in the last 10 or 15 years. So if you go to any practice, I'm sure it's the same way in your own institution. Neurologists are actually very subspecialized now, and they're less and less general neurologists. Traditionally it used to be mostly general neurology that would take care of a neurologically ill patient, but now I think it's mostly subspecialized neurologists.
Awesome. No, I can just echo that experience that you had as a resident. I can remember actually rotating on your service as a medical student and seeing a patient come in with paralysis of I think it was the right upper extremity, and you performing a mechanical thrombectomy on him. And I remember the next morning I was fortunate enough to be able to go see that patient, and they were moving their arm and hand and everything. And it was just a dramatic change. And so that to this day has had an impression on me.
I agree. I think it's something that you don't see in many fields in medicine. I mean, a lot of obviously physicians do amazing work and they take great care of their patients, and they all have, a lot of fields have amazing outcomes and advancements in the last 10 or 15 years. But I think the power of like lifting disability from someone's life, someone who was actually going to spend the next 15 or 20 years of their life disabled, paralyzed, can't move their arm or can't move the leg, and you actually get them back to normal life completely by doing mechanical thrombectomy on time. I think that has been very powerful. I mean, I hear it from the students all the time. We typically, as you know, from your experience at the University of Toledo, we have about 12 to 15 students interested in doing neurology every year. I think what's attracting a lot of people to neurology right now is mostly the acute treatments that we have in the field of stroke.
Interesting. I guess going off that, I thought we'd maybe take a minute and talk about the training pathways and how one can do this great field of interventional neurology, or from my domain as a radiologist, interventional neuroradiology. I guess one question I have is there really much difference between like an interventional neuroradiologist or an interventional neurologist, or I think another term I've heard is like an endovascular neurosurgeon or a neurosurgeon that specializes in this? Is there much difference, I guess, or?
I think in the neuroangio suite, there isn't really much of a difference. So when it comes to treatment, when you're treating acute stroke with mechanical thrombectomy, or you're coiling an aneurysm, or you're doing endovascular treatment for other vascular abnormality in the brain, I don't think there's much of a difference. The difference obviously is in the medical decision making, knowing what to go after and where to stop, and then understanding and interpretation of imaging, and then also converting to surgical treatment if needed. Okay. So for example, I think neurologists, just because of their medical training, vascular neurology, they're able to provide stroke care from, 911 call until the patient is back to their normal life, right? So they're involved in every aspect of care. We take care of the patients before and after. We're at the front line. We make decisions about TPA administration or blood pressure management or whatever. Radiologists are, because of their background training, they're able to see things differently. Their interpretation of imaging, seeing things on MRIs and CTs thousands of times, usually enable you to see things a little bit differently. So they actually can see the subtle things on, angiography very well. They understand the, anatomic localization, the cerebrovascular anatomy, the correlation of certain things on angiography to MRI or CT. I think they understand it better than other subspecialties. Neurosurgeons obviously have the advantage of doing the surgical care if needed. So a lot of our subarachnoid patients require external ventricular drainage. They require sometimes surgical clipping, so they can give you the, ability to especially for dual trained cerebrovascular surgeons, to be able to do both treatments. Okay, so they can give you a really good advice in terms of, should this aneurysm be treated, endovascularly, or should you treat it surgically? Because they've done both, right? So they give you a really good advice on that. But I think, a well-trained interventional neurologist and a well-trained, interventional neuroradiologist and a well-trained neuroendovascular surgeon, I think they all perform the same in the angio suite. Obviously that's where guidelines are very important. That's where training in a place that would give you the experience that you need from radiology to surgical perspective to neurointerventional care to like medical care. I think that's where it becomes very important that during your training, you're able to work with all of those specialties and learn from all of them so that you can actually understand the disease very well, whether you're a radiologist or neurologist or neurosurgeon.
Gotcha. And as a neurologist, typically, is it the path you went where you would first do a vascular neurology fellowship, or do some people do neurocritical care and then do interventional neurology? Or
so some people do neurocrit care, and I think that's also another great pathway to do neurointerventions. Vascular neurology is 1 year fellowship. Neurocritical care is a 2 year fellowship.
Okay.
And then you do neurointerventions right after. In my experience, at some point you're going to have to focus. So focus on one thing in your specialty. So you can do a lot of things, but you have to focus on one thing that would take up the majority of your time. So it's very hard to practice both neurocritical care and neurointerventions at the same time, because neurocritical care is very demanding.
Sure.
So it's one thing to go around on vascular neurology service and go for 3 or 4 hours on round, but it's a completely different quality of work when you're in charge of 16 sick patients in the ICU. In charge of intubation, centralized resuscitation, blood pressure treatment, antibiotics. So I think that it's very hard to balance both. I'm obviously a little bit biased, so I think the pathway that I took actually worked perfectly for me. I really enjoy what I do, and I think I have all the background training to be able to take care of those patients, whether it's ischemic or hemorrhagic disease, very effectively. But that's a personal bias. Other people may tell you a completely, opposite thing, where they would tell you should do neurocritical care and then go to neurointerventions, or, if you're interested as a medical student, you should do it through radiology or do it through neurosurgery. I think it's, neurology is very attractive in the sense that I'm trying to advertise neurology to your audience. That neurology is very attractive because of the good understanding of the disease itself. So I think understanding the natural history of the disease always helps you when you're trying to apply a treatment. Okay, so what happens to a stroke patient when they don't get treated? What does their life look like? When they come back to your clinic, how are they doing? I think all of those things you won't see in any other specialty. You're only going to see it in neurology. So I think understanding the natural history of the disease and understanding the indications and what to do and when to stop. Is it worth going after a branch that supplies your right temporal lobe? Is it, especially if it comes with a high risk, or should you stop at a certain point when you have achieved good reperfusion of the majority of the brain? So a lot of those decisions, obviously you can pick them up from other specialties, so you're going to learn them no matter what. But I think neurologists have a slight advantage, especially vascular neurologists have a slight advantage in terms of understanding the disease very well, especially that most of the indications now for endovascular treatments are actually ischemic.
Interesting. I guess, and also from my understanding, on the other side, neurosurgeons may do a year or two extra in their training to do this, and then radiologists, from what I understand, usually do an extra year of diagnostic neuroradiology, and then on top of that, they'll do usually a 2-year interventional fellowship, where I think they may try to work in some of those more clinical rotations. So they, because one of the disadvantages I feel like of radiology is we don't get as much of that clinical training that you're mentioning as well.
Yeah, no, I think no matter how you do it, you're gonna have to spend 7 years of your life, learning how to become a neurointerventionalist.
Gotcha.
Whether you go through neurology, radiology, or neurosurgery, it's all going to come down to the same pathway, 7 or 8 years. So you may decide to do an extra year of training. But again, when you're doing your interventional neurology, or I should say neurointerventional radiology fellowship, let's say from a radiology background, I think it's important to interact with the clinical teams and not spend most of your time in the injury suite, right? So you go and round on service. When I was in training, I used to round with the neurosurgeons because they were taking care of all the subarachnoid patients. So I'd show up and round with them. I had minimal exposure to subarachnoid hemorrhage on the neurology service in Pittsburgh. So I would round with the neurosurgeons and, round with the residents and just, listen and watch and learn from my colleagues and, give my input when it's needed. And I think regardless of which domain you come from or specialty you come from, even if you're a neurosurgeon, I think you're going to have to learn ischemic disease at some point. You have to learn the indications, which patients to take, how to stent, not stent. A lot of decisions are made during interventions. And, I think you just definitely have to. This is the beauty of this field. It's actually a multidisciplinary field. And today we were having a case conference at noon. We had a cerebrovascular surgeon log in. He gave his input over 5 or 10 minutes. We have a couple of neuroradiologists actually logged in, and they were very helpful in imaging interpretation. And obviously the vascular neurology team. So, medical students, as you can imagine, they love it, right? Because it's a truly multidisciplinary team. And this is how you can provide the best care for cerebrovascular patients. You really have to get input from each service. The nice thing now is that there's a credentialing or certification process that actually involves the 3 specialties. So no matter how you train, you end up getting the same certification through the American Board of Medical Subspecialties. American Board of Medical Specialties. So ABMS has a certification process to be able to certify as a neurointerventionalist. And they have delineated pathways from neurology, neurosurgery, or radiology. So you have to have minimal training, and then you have to to do a certain number of procedures and a certain fellowship to be able to qualify for the certification. But I think that became very important for the field because people are coming from different domains and different specialties. And I think it's really important to understand how the certification process works.
Gotcha. I guess kind of closing things out here. Are there any, I realize it's probably ripe with new innovations, but I guess, is there any 1 or 2 that you're particularly excited about in your field that have come out or are on the horizon?
I mean, there are amazing things happening right now in our field. So I talked to you about stroke thrombectomy, taking clots out. I talked to you about treating hemorrhagic disease, which a lot of students have seen during their rotations. Coil embolization, fluid diversion, those have been around for at least 10 years. So a lot of things have matured in terms of treatments. But now people are starting to look into advancing endovascular treatments pretty significantly. So 2 of the most exciting things that I've come across recently, actually I should say 3. One is for treatment of patients with intracranial hypotension. Okay. One of our colleagues at Mayo Clinic, Dr. Bridge, actually is leading the way on this, and he's a neuroradiologist in training. He has done interventional neuroradiology fellowship and has been at Mayo Clinic for several years. And he identified a certain subset of patients with intracranial hypotension who could benefit from transvenous embolization of a CSF to venous fistula. A lot of those leaks are many times spontaneous, sometimes they can be traumatic, but they happen in the lower thoracic, upper lumbar region. So with CT myelography, he's able to identify the areas of suspected leak and then go transvenous and seal the leak with transvenous embolization. So this is really a very impressive treatment for a disease that's very, very tough to treat. Another indication that I think people are looking into now is shunting. So, VP shunts have been around for a very long time. They're very effective, but they come with their own challenges. Many times you have to do shunt revisions. Sometimes the shunt can malfunction or kink, or you can have infections. So there's a group in Boston that's looking at using the transvenous route, so going through the petrosal sinus, to be able to create a shunt with a very small valve from CSF to the venous system. So, they showed, I think, first in human recently, and it's going to be a really exciting indication if it matures. Obviously it's going through clinical testing, and I think it's going to probably take about 2 to 3 years for this to mature, but this is a big indication for endovascular treatments. The most impressive one, which I left to the end here, is the brain-computer interface. When I was in Pittsburgh, the Department of Neurology and Department of Physical Medicine and Rehabilitation have done really impressive work on getting grid type of electrodes, surface electrodes on the brain, to allow a patient to allow the system to interpret EEG to be able to move an artificial limb practically. Okay, so you use machine learning, you use certain algorithms to be able to convert your EEG waves to real signals for software to be able to move an artificial limb. Now, obviously, the downside is, nobody can walk with grids on their brain immediately. With surgical exposure, there's a high rate of infections. There's a high rate of surgical complications. So this can be applied in certain cases, and it has its own indications, but it can be applied in certain cases. It's not widely applicable. And there's a very large number of patients who live with disability due to spinal cord injury or due to lower brainstem injury or, even corticospinal tract injury. So there's a group at Mount Sinai Hospital that's working on a stentrode, which is a stent that you implant in the superior sagittal sinus. And I actually, invite you guys to read about it. It's very, very important to kind of learn what's going on, especially for medical students. This is a very exciting field. So, those guys have been able to get a flexible stent that has multiple tiny electrodes to be able to do this EEG interpretation. So it's implanted endovascularly, minimally invasive. There's no surgical exposure. You're not exposing the brain. And they also have done, I think, 2 or 3 cases in ALS patients to be able to get the patient to use their thoughts to, produce words through a computer or to actually even move an artificial limb. So this brain-computer interface, I think, is going to be the next 5 or 10 years, probably the most exciting thing in the next 5 or 10 years in the field of neurosciences overall. But I think specifically in the field of, endovascular neurology, I think it's going to be really exciting. And a lot of work is being done on this right now. There are a couple other companies that are looking at the brain-computer interface, but I think this is a huge topic that will only move forward in the near future. There's lots of resources that are being put behind it, mainly because, with everything that we do, for example, in stroke, with everything that we do and all the exciting treatments that we have, there is probably about 30 to 50% of patients that are left with very significant disabilities. So, you optimize your system of care, you train your medics, you have a very efficient team, you bring patients on time to the right place. And, with all of that being done very effectively, you're reaching about 50 or 60% rate of independent living. So there's still a lot of disability from neurological diseases. And I think there's room to try to find a way to work around the disability. And I think brain-computer interface science is actually a very attractive field, and I think has a lot of potentials in the next few years.
Wow, that's incredibly exciting. I definitely will check that out for sure. And it's really exciting that you can implant that from the endovascular side of things. I wouldn't even have conceived that before you told me. I was kind of wondering at first, is he really going with an endovascular route for this? And that's just amazing that they can do that.
That is remarkable. I mean, this company and I think Dr. Oxley is the principal investigator and the person who designed this stentrode. I think it's been remarkable. I mean, just watching this evolving. I heard about it back in 2012. And just to see this maturing to the point where actually there's a first in human implant and it's actually working to a certain extent. Obviously, there's a lot of optimization that has to be done. There are limitations, as you can imagine. EEG interpretation is not easy, and you can have anatomic variations. You can have you want to avoid complications when you're implanting things to improve humans' life, right? So you want to avoid things like thrombosis or disconnect between the stent and the computer interface. So, I think a lot of this work will be done over the next 5 years, but there are a lot of smart people working on it, which is really impressive. Very exciting.
Very exciting. Well, I guess to close this out, I'll ask you the question we ask everybody. When you're not doing all of the things that you're so busy, active in, what do you do with your time outside the hospital with when you do have it?
So I spend a lot of time with the family. I have 3 young boys, and go with them to sports or whatever activities they want to do, and spend as much time with the family as possible, which is very essential. And then I play tennis, I play soccer, try to stay active as much as possible, and I travel. I always tell the students and the residents that good vacations make good doctors. So always try to go on vacation every 3 months or so, and try to take a week off and get out. The job is very stressful, and it became 10 times more stressful during COVID, right? So I think to preserve your own well-being and be able to deliver your best to be able to take care of others, you have to take care of yourself, right? So I think it's very important that you take good vacations, every 3 or 4 months, especially for people who live in our part of the country. It's very important to get out in the winter for about a week every couple of months or so. So, I try to make sure, last year was tough because there was not much traveling going on. But this year, hopefully things are, starting to get better. And, I try to travel at least 3 to 4 times per year. I try to at least make one trip overseas every year.
Very cool. Very cool. Well, Dr. Juma, thank you again for joining us. And I think the listeners will definitely enjoy hearing your perspective and your experiences. And again, thank you so much for taking time out of your very busy schedule to sit down with us.
Oh, you're welcome. Great seeing you again. It's been 2 years now since you left?
Yeah.
Yeah, absolutely. So, great seeing you. And we're always proud of our students and graduates doing great things when they leave. And we have a number of interventional neurologists now graduating from previous classes. I think people who did medical school at the University of Toledo, and now they've finished their neurology or radiology training, and they're starting to go into our field. So that's always exciting to see. It's really probably the most exciting part of our job as educators, is to see people finishing their training and achieving things that they wanted to achieve. Again, thank you for recording this podcast, and I wish you guys all luck. And hopefully this was helpful for people to make any career plans and try to understand the field a little bit better. It's a very exciting field, but at the same time, it could come across as an intimidating field a little bit. We're all very busy, so we're all guilty of not talking to the medical students as much as we should. So there are tons of resources out there if you guys want. There's a Society of Vascular and Interventional Neurology that I actually recommend to all the students to get involved in. And then there's the Society of Neurointerventional Surgery, which actually also has a very strong presence for medical students and trainees. So I would actually encourage you guys to get involved in those two societies. They're fantastic, and they have every yearly meeting, they have dedicated conferences or work groups for medical students to be able to learn more about the specialties.
Very cool. Very cool. Yep. Thank you.
Thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. More episodes are available on our website at dviacademy.com, our YouTube channel. They're also available on Spotify and Apple Podcasts. Also on our website, you can find our video courses for anatomy, biochemistry, and histology, and they're available as month-to-month packages. They're also available as a combo package where you can get all 3 courses in one. Our website also has a store where you can find our outline format textbooks for anatomy, biochemistry, and histology. All textbooks are available in paperback version and as eBooks as well. These textbooks complement our video courses and provide a nice addition to the learning experience of allowing you to focus on the learning and not having to write anything down. On our website, we also provide a free clinical cases video series called DaVinci Cases. DaVinci Cases aims to help you learn how to answer USMLE questions and apply concepts that you learn in our courses to answering those questions. Our cases cover a variety of topics and organ systems, and they're updated frequently with new cases. And then lastly, on our website, you can find our blog, which has interesting articles that cover medical history, important figures in medicine, and innovations in medicine. Again, thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. Please be sure to tune in for our next episode.